You do? Oh, open file. Oh no. This better not have messed with this. Okay. Okay, so the first thing we need to go over in regard to psychological disorders is, okay, so this chapter, chapter 15, is all about psychological disorders, and we're gonna go over it for 2 weeks because I think this is one of those areas that students are really interested in. Additionally, it's a vast topic that I have a little bit of expertise in, and I also teach a class called Abnormal Psychology. That's something you can take after this if you're interested, in which for 16 weeks, this is all we go over are psychological disorders. So if that's of interest to you, think about taking it. And so this is, and we use different terms in regard to like psychological disorders. And again, some will consider these courses to be called abnormal behavior. Others will call them a class called psychopathology. So if you transfer to another institution and for whatever, maybe you're majoring in psychology, you are going to see courses that are called Intro to Psychopathology or Advanced Psychopathology. You're probably not going to see abnormal behavior. So just know it's the same thing, we just use different words. Nonetheless, all of these courses or this area of study, it's a study devoted to understanding, treating, and preventing psychological dysfunction. And when it comes to that, yes, we talk about the disorders, we talk about how we currently treat them. The thing about psychological disorders is there is no such thing as a silver bullet with psychological disorders at all. And so treatments are constantly evolving. We talk about the causes or the correlations, relationships between a variety of variables and the development of psychological disorders, because there is not one psychological disorder that we are certain is caused by one specific variable. So we talk about correlations involved in that. And preventing psychological dysfunction, that's pretty tough, but we talk just a hair about it to a certain degree. But nonetheless, this is referred to as psychopathology, or the symptoms that cause these experiences. So that is this field of study. Okay, so here's the first thing we need to talk about, because again, the course that I teach is called Abnormal Psychology, and so we gotta talk about abnormal behavior. It's a spectrum. It is a spectrum, pretty much like everything else we talk about. It's not black and white, and it's a spectrum. So we're talking about abnormality. Okay. So, okay, and then over a little ways, I'm going to put normal over here, and we're going to talk about the concept of normal in just a second. But normal is going to be on one side of the spectrum. Then, over here, maybe you have like abnormal. And when I say something that's abnormal, something that's just like weird, but it's not psychologically pathological. So this could be something as simple as like define social norms. So if you, I recommend doing this. If you walk into an elevator, what you usually do, you walk into an elevator, okay, you're looking at the back, you turn around and look at the floors that are passing. So you're like, okay, let's get to the 30th floor, let's hurry up. Go into an elevator and don't turn around. Go to a full elevator sometime, don't turn around, just stare at people. That is incredibly abnormal. I've never seen anybody do that, and it would make me super uncomfortable. But try that out, see what happens. That would be an example of like abnormal, but that doesn't mean that somebody has a psychological disorder. It just means that they're doing something weird. Huh?
They're built different.
They're built different. And so that's why not every abnormal behavior is going to be pathological in nature. Again, that's why there's a range. And so we have abnormal, and then over here on the other end, we will have psychological, too bad I can't spell, psychological disorder diagnosis. But then there's another area right here, we'll talk a little bit about it. You can also have traits of the psychological disorder. You don't necessarily, in a lot of cases, people won't be diagnosed with a full-blown disorder, but they might have traits of it, which means that they have some of the symptoms, but not enough for a full diagnosis. And so it's a little less severe, but we're still probably going to treat it. So you might have traits of a disorder. So that's kind of the spectrum of abnormality. And again, I'll try to explain what this is a little bit more. And this is all subjective. It's all subjective. It's culturally based. It's based on what point in history are we, because again, all of these things shift as time goes on. It is difficult to determine when behaviors, thoughts, and feelings become unusual or distressing, or is getting in the way of somebody's functioning, or if they're dangerous for that matter, if they pose a danger to oneself or to others. And so this is why we use the continuum of abnormality. But again, it's going to be subjective. All right, I know I'm going to ask a question about this on the exam. I always do. You do need to know the 3 Ds of psychological disorders. You have to have these 3 in place, except for a few caveats. There's a couple disorders where it's a little bit sketchy with these 3. But you have to have these 3 Ds in place in order to diagnose somebody with a psychological disorder. If you don't have these, you're probably not going to be able to diagnose them very easily. So, first one is going to be dysfunction. Okay. Whatever they're experiencing, the symptoms that they're experiencing are going to interfere with their ability to function in daily life. So, an example of this is if somebody has major depressive disorder, okay, and they're going through a depressive episode. It is not outside of the norm if somebody's going through a major depressive episode. It might be hard for them to get out of bed. And usually there's somebody that will pop out of bed and go to class or go to work, and they haven't been able to get out of bed for like a week. That is dysfunction. That is absolutely dysfunction. You haven't been able to get to class for a week because you're just depressed and you have a hard time getting up and going. That is dysfunction. It's getting in the way of you functioning. Or social anxiety disorder. You're not responding to friends anymore. That could be another dysfunction. Distress. Yes. Honestly, if people are showing up to get treatment for something, they are probably experiencing distress. If there's no distress, they're not going to show up in a therapist's office, unless it's as the result of the criminal justice system. So it has to cause some sort of physical or emotional pain. So again, we go back to depression. Depression will commonly cause things like amotivation. Again, you're having a hard time getting up and going. Anhedonia. Things that used to feel good, like tacos and puppies, don't feel good anymore. They might feel hopeless or worthless or empty, or they might be experiencing suicidality. Those are all examples of distress. And even in some cases of depression, there is physical pain. There is actually, what's the word? It's not like sharp pain, kind of like aches. Aches is what is commonly reported. All right, also, now we're to deviance, okay? What is it and it's not abnormal? It has to be outside of cultural norms. So, for example, schizophrenia. With schizophrenia, you will commonly, in regard to the positive symptoms, positive does not mean good in this class, or in psychopathology. It means something that's added that shouldn't be there. So within schizophrenia, you will commonly have either hallucinations or delusions. And in our society, it is not normal for example, like right now, me to be like, there's like floating faces in that wall. And you guys are like, that's not there. That's not there. Something's wrong with it. Yeah. No, that is outside of a cultural norm. We do not expect people to hallucinate or believe that the FBI is going to come out and get them. That would be a delusion. Now, that's in our society. There are societies out there, and I'm sorry for not being able to identify one right now, but there are societies in which individuals who are schizophrenic are actually considered to be sacred and they're revered, because those hallucinations that they have are conceptualized as like, oh my God, these people can see things that we can't see. They have the ability to get in touch with another realm. So they consider these individuals they're not mentally ill, they're sacred. So in that culture, it's not deviant. It's outside the norm, but not in such a way that it's causing dysfunction. These people are going to be considered to be revered. So again, it has to be outside of cultural norms. Okay, and then taken together, this is going to make up the professional's definition of behaviors and feelings as abnormal or maladaptive. Yes, especially if they're in the extremes. But there are subjective judgments that are made because, again, all of these conceptualizations are created by humans, and humans are fallible. So as a result of that, there's going to be subjective interpretations. That's why diagnosis can be so difficult, or over time, somebody's diagnosis could evolve, could become minimized. And on top of it, we use what's called the DSM, which I'll talk about in a few minutes. But the DSM is kind of like our Bible, but unfortunately what it does is what is in here are specific symptoms that you have to have a specific number of symptoms in order to be diagnosed with a disorder. But the thing is basically we've created boxes to put people in with this DSM. And nobody's experience with psychological disorder is going to be the same as somebody else's. Everybody has a unique experience. And so that's why you have to have subjective interpretation as a professional clinician. Okay, now when it comes to distress, specifically, because, again, distress is part of the diagnostic criteria, but distress is normal in some situations. It absolutely is. So, for example, I had to give a speech in public on Sunday, and I was incredibly nervous. Like, I was super duper nervous. I was experiencing emotional distress. I don't like talking in public. I can talk to you guys. You guys are safe. In public, absolutely not. But the thing about that distress is it was normal, okay? A lot of people don't like talking in public. A lot of people have phobias of talking in public. And so as a result of that, that's not a distress that would warrant like a psychological diagnosis. I'm not going to get diagnosed with an anxiety disorder just because I had a hard time speaking in public. Not going to happen. So distress is going to be normal in some situations. Also, another example would be like if you lose like a family member, somebody close to you dies, you're going to be distressed. You're going to grieve. That is normal. That is absolutely normal. We will talk about prolonged grief, though, in a second as well. Yes, dysfunctional distress occurs when a person is much more distressed than others would be, and for a longer time. So, impairment, it must be pervasive and or significant. So, again, talking about grief. We do have diagnostic criteria for prolonged grief disorder. That got added in 2022 as a result of COVID. And the criteria, it's either 1 year or 2 years, but I think it's 2. If you experience a loss in your life and you are grieving, the grieving has to be pervasive for at least 2 years to get that diagnosis. And not only pervasive, it has to be like you have to experience the symptoms of it every single day for most of the day. Because what happens naturally with grief, or within our culture, I should say, is that, yeah, grief can be overwhelming. It can be chronic to a certain degree, but as time goes on and you go through the grieving process, it starts to become a little bit less. I am kind of the opinion that grief never completely ends. It comes in waves, but there's points in time at which it should recede a little bit. But with somebody who has prolonged grief disorder, it is at like a 10 at all times for at least 2 years. And again, you have to consider what is normal in a culture in order to consider this, but nonetheless, if we're talking about a psychological disorder, it has to be a harmful dysfunction. So you have to be distressed to the extent that it is getting in the way of your life and it is not normal in society. Okay, we can skip this. We talked about it. So this is kind of the accepted definition of a psychological disorder. And it's pretty loaded, but it's everything we just went over with the 3 Ds. So it's going to be a behavioral, psychological, or biological dysfunction that is unexpected in society or in your culture, like we talked about, and it's associated with distress, like in that emotional or physical pain, and impairment in functioning. So you have the dysfunction as well. Or increased risk of suffering, death, pain, or impairment. So that's going to be important there, because there are a couple of disorders, specifically personality disorders, in which an individual may not be experiencing, they might not be interpreting their experience as distress or dysfunction, but it actually is. And that is a whole other ball of wax. Okay, so we're not going to go over the historical implications or historical approaches to mental illness. It's been a hot mess for a long time. We just stopped doing lobotomies in the late 60s, early 70s. So it's been about 50 years since the last formal lobotomy was completed. It has not been very long. We are not very far from lobotomies, which tells us that we are not an extremely evolved field. Okay, so what I want to talk about here in this is that, okay, so you guys do need to know, okay, the DSM is the Diagnostic Statistical Manual of the American Psychiatric Association. It is how we come to a conclusion as to whether or not somebody should be diagnosed with a psychological disorder. The current version is the DSM-5-TR. That will be on the exam, I'm pretty sure. Okay. This is what it looks like. Sorry, that is an S. That is an S. Okay. This was released in 2022. The first DSM, the first categorization of psychological disorders was like back in the 1920s, 1930s. And with that, the first formal DSM was released in the 1950s. And I'm just going to say that when it comes to the DSM, we have not been incredibly helpful in progressing society. In certain ways, we've held society back because of how we've conceptualized certain psychological disorders. So, for one of the first disorders that is, again, it was kind of, again, holding women back, stigmatizing women, was the concept of hysteria. Women could be diagnosed with hysteria. And so this could be something from as simple as a woman experiencing depression to maybe anxiety, or maybe they're just not acting the way that men want them to act. They could be diagnosed with hysteria and potentially institutionalized. But stigmatized nonetheless. But then we got rid of that. Another diagnosis that was not removed from the DSM, it was only removed 50 years ago. It was not removed until 1972, was homosexuality. So before 1972, you could be diagnosed with homosexuality if you were gay, and you were considered to be psychologically ill. Until 1972. And unfortunately, even though it was taken out of the DSM in 1972, clinicians continued to diagnose it through the 1990s. Now, obviously, this did not help the LGBT community, because it further stigmatized them, and what it did was conceptualize who they were as mentally ill. So it really aided in holding back the LGBT rights, or LGBT rights in general. But luckily, again, we've gotten to the point where we're like, okay, that's not a psychological disorder. It is who they are. It's not psychologically disordered. I mean, the way that the LGBT community is treated does cause distress in people, but it's not because of who they are, it's because of the way society treats them. And so that goes to the next diagnosis. Until 2013, individuals could be diagnosed with gender identity disorder, and so if you were not cisgender, you could be diagnosed with gender identity disorder, and that's it. You did not necessarily have to have that dysfunction or distress. You could still be diagnosed with it just because you did not identify with your biological sex or gender. It was not until 2013 that we revamped that diagnosis, and now that diagnosis is called gender dysphoric disorder. And so the diagnostic criteria for that is not primarily based on like internal distress or dysfunction of an individual, it's based on society. So to get that diagnosis, you have to be, you need to be non-binary, gender-wise, and you have to experience distress, dysfunction, in a manner that is responding to society. So again, it's not the result of not identifying with your birth gender, it has to do with the way society treats you. Because as we know, like transphobia is rising in our society. People who are trans are at an increased risk of assault, murder, and just being discriminated against and stigmatized. And that experience in and of itself is distressing enough to cause functional issues in these people's lives. And as a result of that, you can get this diagnosis because society treats you like crap. That's literally why we have this diagnosis, because of the way people treat trans people. And until we stop it as a society, this will continue to be a diagnosis. Until these individuals are conceptualized as people in our society, there will still be this diagnosis because society treats them like crap. Okay. So again, you can kind of see how psychiatry, psychology have held back the rights of a variety of groups of people. All right, then in 2022, we had the release of the DSM-5 TR. TR stands for text revision, and so instead of releasing a completely new DSM, they were just making a couple of changes. That's why it's a text revision. It's like an amendment. So what they did in the DSM-5 TR is they added a couple of considerations a couple of cultural considerations in regard to language, and then they added the diagnosis called prolonged grief disorder. This was directly in response to COVID. Even though we've needed this disorder for a long time, It had not been added, but now we have the disorder called prolonged grief disorder. And again, COVID is still out there, still killing people, but it's not, the rates of, it seems that society is not as concerned as it was. Society is not responding in the same way that we were 4 years ago. And so what occurred as the result of COVID is maybe you lost somebody you love to COVID. Maybe somebody you love has long COVID. Maybe you have long COVID. Maybe just the fact that society shut down completely distressed you to the point that you were grieving. I think to a certain degree, everybody grieved during COVID in some way, shape, or form. And so as the result of that, psychiatrists, psychologists were like, oh my God, there's this grief issue in society, and we need to treat it. And here's the thing, is that we used to kind of, with grief, we used to kind of diagnose like major depressive disorder and if you were grieving substantially. But grief and depression are two different things. There is depression and grief, but there's so many other things within grief, you can't put it under depression, under the category of depression. You just can't. And so we needed this because so many people were grieving. And so as a result of COVID, we developed this diagnosis. And again, like I was saying, I believe it's 2 years. You have to be experiencing prolonged and excessive grief for at least 2 years to be diagnosed with this, and you can be treated. Probably by 2030, we'll have a DSM-6. It's about every 10 years they put a new one out. So that's kind of the evolution of psychological diagnosis within the last 100 or so years. And again, 100 years is not much time. It's not much time at all. And so this is still a very new area of study, experimentation, research, because we do an okay job of treating psychological disorders, but it's not great. Okay, so with that being said, do you have any questions about any of that? All right, and if you are reviewing for the exam, that is going to be under the Abnormal Psych Module 1. What is that? PowerPoint, just in case you need that. I don't care about OneDrive. Okay, the next one. Okay, we're going to talk about mood disorders. Now, outside of, and I'm kind of picking and choosing different disorders. Again, I got to condense 16 weeks into 2 weeks. So we're going to start with mood disorders because mood disorders, everybody to a certain degree is going to be able to easily understand mood disorders. If you do not have a mood disorder, you probably know somebody that does. So it's usually a good place to start with diagnosis. And so when it comes to, there we go, mood disorders, what we're looking at, and along with like your depressions, we're also going to conceptualize bipolar disorder. Both are categorized as mood disorders. And so with mood disorders, we are interested in what are called gross deviations in mood. And so this is a spectrum as well. Well, it's a spectrum, but it's like it's a spectrum that has poles. And so, okay, you've got a spectrum, there are 2 poles on each end. And so when it comes to mood disorders, okay, I'm going to put normal here. I don't know what the heck normal really is. I guess normal is like somebody that feels just kind of okay most of the time, but they don't get significantly depressed or manic. So I guess that's kind of normal. But on one end of this is depression, and on the other end is what we call mania. Now mania, yes, conceptualized here per the publisher is an elevated mood. It can be elevated, but it's like an expansive mood. So, because some people are like, yeah, I could use a little bit of mania right now. No, you don't want that. You don't, I promise. Yes, some people's mania is like euphoric, so they feel really, really good during it. But then they do really impulsive things sometimes. But there's also people who experience mania that is just, it's an expansive mood, and sometimes it's euphoria, but sometimes it's like irritability and frustration that they just can't control, because there's so much activation in your central nervous system. So it's not necessarily great. All right, so we've got mania, and then we have what's called hypomania. Hypo means under, and so it's just like a less extreme form of mania. It's a lower level mania. But this would kind of be the spectrum in regard to mood disorders with poles. So yes, we have major depressive episodes, manic episodes, and hypomanic episodes. And in order to get to a diagnosis of a mood disorder, we have to determine what type of episode is the person experiencing. That's the way that we get to a diagnosis of these. And we have two types of mood disorders. We have unipolar and bipolar. I think you guys are going to get this pretty easily. Unipolar mood disorders. Uni means one. Unicycle, one wheel. Awesome. So this means that you are only going to experience one of the poles. You're either going to experience just depressive episodes or manic episodes. Depression alone or a depressive episode is going to be much more common than mania alone. So people with major depressive disorder, that's a unipolar mood disorder. I have never met anybody with bipolar 1 disorder that has only experienced mania. There's almost always depression involved, but it is possible that there are people out there that only experience the manic side. Okay, then we have a bipolar mood disorder. Bi means two, so we're going to use both poles here. This is when somebody experiences both the depression end and the manic end. This is literally bipolar disorder 1 and 2. All right, so some of the unipolar mood disorders, well, these are all the unipolar mood disorders in the DSM-5 TR. You got major depressive disorder, that's the one we're going to go over. There's also persistent depressive disorder. Persistent depressive disorder is going to be more chronic than major depressive disorder. So with major depressive disorder, an episode is going to constitute 2 weeks of symptoms. Persistent depressive disorder requires approximately a year of symptoms, but it's a little less severe. Premenstrual dysphoric disorder, we finally have a disorder for PMS. And yeah, this one is, they say that it's controversial. It is not. If you are a woman who has experienced PMS, you know like the extreme mood issues that come along with it. It should not be controversial. Unfortunately, when it comes to the conceptualization of these diagnoses, historically it's been primarily men. So for guys, this might be hard to conceptualize. Representation matters. Okay. Disruptive mood dysregulation disorder. This is primarily going to be diagnosed in kids, anybody under the age of 18, and it's primarily used to diagnose bipolar symptoms. It's used in order to lessen the stigma, and so instead of diagnosing a kid with bipolar disorder, you're possibly going to just diagnose them with disruptive mood dysregulation disorder in the hopes that they don't experience as much stigma as if you diagnose them with bipolar disorder. And with these disorders, yeah, they're characterized by a range of symptoms, but you only need a certain number of symptoms in order to be diagnosed. So there might be 10 symptoms available and you only need 5 and you can get a diagnosis. Because here's the thing, everybody has different symptoms. And so these are absolutely heterogeneous disorders and that everybody's going to be unique and experience these things differently. And again, this is what makes this, the job of diagnoses, pretty tricky, but it's kind of like a puzzle, is what I think. Okay, so major depressive in order to be diagnosed with major depressive disorder, you have to have at least one major depressive episode. And this is important because these episodes are going to be basically plugged in to disorders in order to diagnose you. So with a major depressive episode, this is the criteria. Even though I'm going to read it from the DSM, I need to update this PowerPoint. The PowerPoint isn't great on this, but you have to have at least 5 of the following symptoms for at least 2 weeks, and that 2 weeks has to be most of the day, every day. So it can't just be like, oh, I had a rough day in the last 2 weeks. No, it has to be about 14 days straight of depressive-related symptoms that are most of the day. You can say like, okay, yeah, I had like 3 days of depression. Oh, that doesn't count. It has to be at least 2 weeks. And usually people who do appear to receive treatment for major depressive disorder, they're not like at the 2-week mark and they're like, I need help. No. Usually people who are experiencing depression, they're going to wait it out for a long time. So they might not come in for like 6 months or years, for that matter, unless it's incredibly severe. Okay, so the first criteria, and again, you only need 5 of these, and you can mix and match, depending upon the symptoms a person has. So you have to have a depressed mood most of the day, nearly every day as indicated by either, your report or somebody else's. So when we talk about depressed mood, that could be like hopelessness, emptiness, a lack of self-esteem or self-worth. And I'm just going to, because I was diagnosed with this almost 20 years ago. So this is absolutely anecdotal to anybody that's watching this, or you guys, if you have major depressive disorder, your experience with depression might be a little different, but I've been able to conceptualize depression a little bit differently than sadness, because it says like sadness up here sometimes. Yeah, I feel sad. Sadness and depression are two different things. It was conceptualized very well yesterday by a student, in that like sadness is like a tunnel, in that you might feel down or negative or sad for some time, but you know there's a light at the end of the tunnel. There's a certain amount of hope. There's a certain amount of hope, and you will get to the end of that tunnel. When it comes to depression, on the other hand, it's like a cave. You go into that cave and it's dark. And there's no way really out. There's no way through a cave. A cave end. There's no end to a cave. There's only walls. And so when people are experiencing depression, again, that's the best way I can experience it, is that even if, so for somebody like me, I've had 20 years of treatment, I have coping skills, I'm pretty self-aware, I know how my depression works, but you know what? Every single time I have a major depressive episode and I end up in that cave, my brain reverts to, there's no way out of this. That's the difference between sadness and depression. Depression, regardless of how well-versed you are or educated or know yourself, when you are in that cave, you are convinced there's no way out. That's where the hopelessness and the emptiness, and for some people, suicidality comes into play, because there's no way out. They are convinced there's no way out, because anybody looking from the outside would be like, well, yeah, it's going to end. Yes, that's great and everything, but when you're in the middle of it, it does not feel like that. Whereas sadness, tunnel with the light at the end of it. Okay. So when they say, like, I feel sad, I'm sorry, I disagree with DSM on that. Also, things like they're more tearful than usual. Maybe? Again, that's not been my experience with myself. That's also not been my experience with clients or students who have depression. In most cases, when they are depressed, you don't recognize it. Unless you can see, like, okay, they're not getting out of bed anymore, they're not coming to class anymore, they're behind on their homework, things like that. They're not eating as much, they're eating too much, they're not sleeping. Maybe you notice those things, but like the symptoms of the actual depression, like the feelings, you don't see. People are very good at hiding those symptoms. So in regard to them being more tearful, not necessarily. No. A great example of that is like Robin Williams. I know that's not necessarily why he completed his suicide, but again, one of the funniest people on earth. You never would have guessed he was depressed, but he was. Okay, so that is one thing. You have to have a depressed mood. And that is a requirement. You have to have again, if you don't have a depressed mood, like, you're probably not reporting this to a clinician. Also, you have to have, I shouldn't say have to, because you only need 5 of these. You have a diminished interest in, you have diminished interest or pleasure in all or almost all activities most of the day, nearly every day. So this is called anhedonia. Anybody out there that's interested? All right, for me, here's my example of anhedonia. Tacos and puppies don't feel good anymore. Like when I am, and I do experience this, and also another, like, I can kind of tell when I'm experiencing anhedonia because I'll get in the car, I'll put my music on, and I don't feel anything. In general, when I play music, I feel something. I feel emotion. I feel good, or it gets me pumped, or maybe eliciting emotions from like happiness, things like that. But when I'm experiencing anhedonia, I put that music on and I don't feel anything. Or other examples of this, you might not go out anymore. You're not responding to friends. You're not going in. You're not going to class. You're not going to your clubs. You're not going out. Maybe you're not responding to people as much. Okay, so that is that one. And then also, okay, these are again different polls. People can end up on any one of these, but you either eat too much or you don't eat enough. So your appetite has shifted. Your appetite has shifted in some way. And usually there's a significant weight loss when not dieting or weight gain. And clinicians usually look at, okay, like have you gained more than 5% or lost more than 5% of your body weight in a month? And so if you have, they would consider this. Also, insomnia or hypersomnia nearly every day. Again, it can be on either end of the spectrum. Some people who are depressed don't sleep. Other people who are depressed sleep all the time. That's me. When I am depressed, no, that's all I want to do. I want to sleep. That's all I want to do. I don't care about it. I just want to sleep. And so I've learned that when I am depressed, naps aren't allowed. I'm not allowed to sit down on the couch and watch television during the day. No naps, because it just really actually enhances my depression. And I like my naps. When I'm not depressed, I nap. It's beautiful. When I'm depressed, I refuse to allow myself to. Because that's all I want to do, sleep all the time. Okay, another example, there we go, we'll go to the next one. And this isn't in order exactly on the screen. Psychomotor agitation or retardation nearly every day. And so either you feel restless and like you just can't sit still, you can't get comfortable, you just gotta move, or you just like, it's hard to get up. It literally it feels like you're heavy. Like you need to get up and let the dog out. Like it's just like you're carrying 1,000 pounds on your back. It's like every movement is almost painful and torturous. So obviously you know where I fall on that one. So you're either restless or you have a hard time doing anything at all physically. Okay, another one, fatigue or loss of energy nearly every day without doing anything. Depression is absolutely exhausting. You don't have to do the damn thing. You don't have to do anything at all. Like you can get up and take a shower and you're exhausted. You are just constantly fatigued for no reason at all. You have no energy. That is extraordinarily common. Let me see here. Yep, feelings of worthlessness or excessive or inappropriate guilt. Which may be delusional. It's usually delusional in nature. But again, the worthlessness, I'm not worth anything. I don't necessarily believe that like I have any purpose. I'm in the way. Now we're getting into guilt. Somebody described this yesterday as like, you feel like a burden. You're a burden to other people. You're a burden to society. You're a burden on this planet. Like, why am I even breathing air? I'm wasting it when other people could use it. That type of thing. And again, that's delusional. That is very, very delusional. When you're not depressed, you don't necessarily have those thoughts. Okay, so there's that. Okay, diminished ability to think or concentrate or indecisiveness nearly every day. Okay, yeah, focus is hard when you're depressed. With my experience, this is why when I am not depressed, I get as much work done as possible. I like jam it out. I'm like, okay, I'm good today. We're gonna get everything done. Because I know when I am depressed, I'm not getting anything done. I can sit at my desk, just stare at the computer, not do anything. Or I'm like, all right, like I'll try to start, and then it's like, nope, TikTok. Because I feel like crap in the first place, and so I'm looking for coping skills. And no, I can't focus on homework. I can't focus on homework. I'm not going to grade very well. There's no focus. Like you cannot zone in. All right. Also, this is one of them. Again, these are all concerning, but recurrent thoughts of death. Not just like the fear of dying. I think that's a normal thing, but recurrent suicidal ideation without a specific plan, suicide attempt, or specific plan for committing suicide. Okay, so again, this is also kind of like a spectrum in that some people, when we talk about suicidality, some people are just like, you know, the world would be better off without me here. Or I really feel like I want to die. Like I don't want to be here anymore. Okay, unfortunately that's a low level of suicidality. That is very concerning. But when people have that, again, if it's low level, they don't have a plan. So they like have those thoughts, but they're not thinking about like, how am I going to get this done, so to speak. When they have those thoughts, plus they have a plan now. A plan is where we get to a level of dangerousness. And so if somebody's got a plan, like they're like, okay, I'm gonna make sure I have this in place, I'm gonna make sure I have this, I bought this, and I'm gonna do it at this specific time. That's when, usually, if you report that to a clinician, they'll be like, we might have to get you to a hospital. Because if you've got a plan in place, if you've got a strategy, that is too far. Because you've thought about it, there's now intent to do it. And so that is the point at which we go from like, okay, we need to talk through the suicidality to you might need to be hospitalized if there's a plan in place. And then obviously from the plan stage, you go to suicide attempt, unfortunately. And you just hope that it's a failure. And then obviously the next step is the completion of suicide. So with this diagnosis, there are 9 criteria. You just need 5. Just 5. Okay, so yes, if you're presenting to a clinician, you're going to be distressed, okay? Like, you're going to be distressed. Especially if you have 5 of these criteria. It's going to cause distress. I just told you about, like, when I experience this, I'm highly distressed. Emotionally, physically, I'm not able to function. So there's a dysfunction as well. I told you, like, I can't function very well. Let me see here. Yep, there's a functioning. It's not the effect of a substance or other medical condition. Okay, so that's your major depressive episode. Now, for a major depression's, okay, we'll go to that in a second. So to be diagnosed with major depressive disorder, you need that. That is it. You need 1 major depressive episode. And you just have to make sure they've never had a manic episode, a manic or hypomanic episode. That's all you have to rule out, and you have major depressive disorder. And when it comes to major depressive disorder, okay, with a major depressive episode, and I'm going to say that a single episode is highly unusual, and I say that because if you have 1 single episode of depression, in most cases you are not going to end up in a therapist's office. The way that most people conceptualize 1 episode is like, okay, that was just a rough point. And they don't. It's not until people start to experience recurring episodes that they're like, or families like, we gotta get you some help. So usually there's going to be recurrent episodes. I'm pretty sure there's plenty of people that experience single episodes. It's just that we don't have data on them because they don't show up in a therapist's office. In 2020, and again, the numbers after 2020 would be super interesting. I do not know if they're out yet, but an estimated 14.8 million adults over the age of 18 had at least 1 major depressive episode. And this number, it's about 6% of people. So about 1 out of every 20 of us is going to have a major depressive episode. Hopefully that's just me and you guys are all clear. Also, an estimated 2.9 million adolescents between 12 to 17 had at least 1 major depressive episode. This is 12% of the U.S. population. It's about 1 out of every 10 teenagers is going to have a major depressive episode. This is really, I'm going to say like 12 to your early 20s is what we're super concerned about. Because that's when depression will commonly like rear its ugly head. That's the age group that I would say professionally that I would be most concerned about. Okay, let's see here. It's more common among adult females. Yeah. The prevalence of major depressive episodes is going to be highest among individuals 18 to 25. That's going to represent 17%. So almost 1 out of 5 individuals between the age of 18 and 25 are going to experience a major depressive episode. So you can see here that that's extraordinarily high compared to all the other age groups here. But again, we don't have kids in here. But another group that is really at risk for having a major depressive episode is going to be individuals who report being more than one race. So if you report being Caucasian and African American, you're at a 16% chance. If you're half Japanese and half Hispanic, you're at a very increased risk. And it has to do with the way that society treats you. It doesn't have to do with anything genetic. It has to do with the way that society treats people of 2 or more races. Just messed up. Okay, let's see what else I got here. Okay, we talked about this. Yep, symptoms have to last at least 2 weeks or more to get the diagnosis. And these episodes do have to be, there has to be a break. There has to be a break. And so these symptoms, okay, they might last 2 weeks, they might last 3 weeks. Some people have symptoms for a month, 2 months, but then there's got to be a break. There has to be a period of remission. And so the way that major depressive disorder looks is that, like, okay, you're okay, you're okay, you're okay, okay. Now, there's the depression. You're in the depression, you're in the depression, you're in the depression. Okay, we're okay for a little bit. Maybe you're okay for a little bit, and then we're depressing. And we're depressed, we're depressed. Okay, we're okay again. So literally there has to be gaps of okayness. And then you drop back down into the hole. So again, 2 weeks or more of symptoms, have to have periods of remission. Let me see what else you need. Yeah, got to get in the way of your functioning. No mania, not another medical condition, no schizophrenia. So basically, 1 major depressive episode. Okay, now here's the thing about what causes major depressive disorder. Is that we don't know exactly what causes it. And so this has made it very hard to treat. But in general, we think it's a complex interaction between genetic and environmental factors. All right, I'm going to be just a little bit vulnerable in here with this one, but mine is a pretty good combination of genetic and environmental factors. Until I was about 25, I did not know that mental illness basically sprints through my family from person to person. It really does. I mean, again, I know I'm being pretty vulnerable here, but well, being videotaped. But like my great grandmother experienced depression to the extent that she was actually institutionalized at the Hastings Regional Center at that time. I am of the opinion that my grandmother also had depression, and my father does as well, and those are undiagnosed. And so I'm pretty sure there's a genetic component here. Now again, just because you have the genetic component does not mean you're going to develop anything. We've talked about that with epigenetics throughout this class. But what happens is that if you carry genes that predispose you to depression, what happens is that if you're in a stressful environment or if you experience trauma, those genes might be expressed. And so, for example, in my case, it wasn't until I was about 18 years old. You know, my childhood, like, I got nothing to complain about, really. We all got stuff, but I really don't. And so it wasn't until I was about 18, I went to college, I experienced way too much, like, things just, like, hit me like a brick wall. Life hit me like a brick wall. And that's when depression popped up. And so, as far as I'm concerned, it is a mixture of me being predisposed as well as environmental stressors. Boom, we have a disorder. And again, that's most commonly when, well, there's a couple different areas where people will start they're more likely to experience stressors like, okay, early teens, that's stressful as hell. You could not pay me enough to go back to that time. Or you're leaving home, you're going to college, you're starting your own life, another time when major stressors occur, thus potentially resulting in depressive-related symptoms. Okay, and there's many different brain areas affected, so there's all sorts of combinations of symptoms. And even okay, so because this is so complex, it affects so many different regions of the brain. It's going to affect, okay, like your executive functioning, your motivation. It's going to affect your emotions. We're looking at the amygdala. It's going to affect your psychomotor abilities. So we're talking about like the parietal lobe. So there are so many ways that people are going to be affected. Okay, so these are traditionally the ways that we treat major depressive disorder and treat mood disorders in general. Is that we historically have used SSRIs, and more recently we've used SNRIs because when it comes to SSRIs, we're looking at drugs like, or psychotropic medications like Celexa. That's possibly, Celexa and Lexapro, those are like starter medications for depression. That's what you might get prescribed pretty early on. Also, Luvox, Paxil, and Prozac. Those are some examples of SSRIs. And what those medications work on is serotonin, because initially we were like, yes, it's serotonin that's causing depression. That's also where we got people have the wrong idea about serotonin. Serotonin is not the happy neurotransmitter. Serotonin is just kind of like a mood stabilizer, and it also has to do with like muscle function, digestion. It's not like the, oh my gosh, I feel really good neurotransmitter. That's dopamine. This is also why, again, this misinformation and misconceptualization of serotonin has led to people will get like the chemical composition of serotonin like tattooed on themselves, and I don't think that they know that serotonin does not result in happiness. Serotonin results in you just like you're just kind of okay, you're just kind of like stable, and again, muscle usage and digestion. They needed to get the chemical composition of dopamine. That is the happy neurotransmitter. But nonetheless, this is why we've misconceptualized it. And also, SSRIs and SNRIs only work on about 50% of people. And so what that tells us is that it's not necessarily a serotonin issue. There's a variety of areas of the brain and neurotransmitters that are affected, and so these drugs aren't going to work for everybody. More recently, we developed SNRIs. SNRIs are they will work on some serotonin, but they'll also work on norepinephrine. So some of those aspects of like, okay, lack of motivation, lethargy, having a hard time getting up and going, having a hard time getting out of bed, that slowing down of things, that is potentially related to a lack of norepinephrine. Norepinephrine is like the adrenaline in your brain that gets you going. And so that's why we have SNRIs. So some examples of this, so things like Effexor, Cymbalta. Cymbalta's nice as well because Cymbalta will also help in treating like the aches and pains that some people have with depression. Let's see, Pristiq, Fetsima. Those are all examples of SSRIs or SNRIs. Let me think here. What do I want to say about this? I'll go to the next one. I think we're good on that. Okay. I think this is an over-exaggeration, but it says that I'm going to go more toward the 50% and a little bit lower than that in regard to antidepressants being effective in people. Yes, they increase serotonin and norepinephrine activity in the brain. Now, here's the problem with this, is that if somebody appears at a clinician's office, and let's say they're extraordinarily depressed and potentially suicidal, and the clinician's like, okay, let's put you on an antidepressant. But here's the problem with it, is that you might not feel the effects of it for 3 to 4 weeks. Good luck. That's a freaking issue. Like, you got somebody in front of you that is highly depressed, hopeless, and maybe suicidal, and you're going to say, like, oh, just wait 3 to 4 weeks? Not great, but that's the truth with SSRIs and SNRIs. You commonly do not experience the effects of them for 3 to 4 weeks. And so this is also indicative of, again, once you take the medication, it is going to work on serotonin and norepinephrine, but you don't feel the effects for 3 to 4 weeks. Also indicating that a lack of serotonin in the brain does not necessarily cause depression. Here's one thing that I will say in regard to advice regarding antidepressants, is that if you are prescribed an antidepressant, and if it doesn't work, and you end up using 2 to 3 antidepressants and none of them work, you should be labeled treatment resistant. And you should tell your clinician this. If your clinician does not do this, you need a new clinician. Because what that indicates is that antidepressants aren't necessarily going to work for you. You are resistant to antidepressants. Effectiveness. And again, about half of all people are going to be resistant to antidepressants. So you're not abnormal. And the other thing about this is that if you are labeled treatment resistant, you are going to have access to newer treatments for depression. Some of these newer treatments include things like electroconvulsive therapy, transmagnetic brain stimulation. You are also going to be eligible for things like ketamine. therapy. Ketamine therapy is incredibly effective. What ketamine does, ketamine will actually, a dose of ketamine, again, this is a very small dose of ketamine, will result in a decrease in depression within about 24 hours. And what ketamine does neurologically is it works within the limbic system and it works its way out to the prefrontal cortex. And when it does this, it aids in creating new pathways. And when it makes these new pathways, of course you're going to be in therapy as well, but what it's going to do, it's going to decrease that depression and aid you in developing, in more easily developing and implementing like coping skills and things like that. Ketamine, initially you had to go to a clinic to get ketamine treatments. Now Johnson & Johnson has actually made a nasal spray of ketamine, so you can now get ketamine at home if you qualify for it. Other treatments that are coming about are things like microdosing, like LSD, mushrooms. Man, I think I'm missing one. Obviously, the utilization of marijuana under a doctor's guise. But when it comes to like LSD, what the research is starting to say is like microdoses are not as effective as a full dose of LSD in regard to depression. One more thing on ketamine, just in case you didn't know what ketamine was, and I should have started with this. Ketamine is a Schedule I narcotic, and that's what makes the research on it difficult, because the government is not necessarily going to approve of research on Schedule I narcotics. But we're making steps. Ketamine is most commonly used in vet clinics. It is used as commonly a small, well, it could be, I think it could be a larger animal, but it's an anesthetic used in veterinary clinics. Or it is abused, and when it is abused, it is going to be kind of like hallucinogenic and depressive in nature, so it's going to calm everything down. Which makes sense because it's an anesthetic. And then at low levels, it can be utilized for depression. It can also be utilized for things like PTSD. So some of these drugs that we have labeled as narcotics or extremely dangerous could be the more effective route to treating depression. So that is all of that. And there's more information. Yeah, ketamine has been found to be effective in 60% of treatment-resistant patients, which is huge. So tons of people who do not have any response to antidepressants, 60%, 3 out of 5 are going to be responsive to ketamine. Okay. Skipping. Okay, I'm just going to start. I have 5 minutes left. I'm going to tell you what a manic episode is. Okay? So now we're on the other side of this spectrum. And, okay. So, manic episode. This is when an individual has an elevated or expansive mood for at least 1 week with abnormal or persistent increase in energy or activity present most of the day, all day, with at least 3 of the following symptoms. So it either has to be 1 week or you end up in the hospital. If you have a manic episode and you end up in the hospital 3 days in, that constitutes a manic episode. So if it's that severe, you can have that cut off. But otherwise, if you are not hospitalized, it has to be at least a week in nature. Where's my bipolar disorder? I think it's in its own. Okay, so again, you're going to need at least 3 of the following symptoms. So inflated self-esteem or grandiosity. I am God. You think way too highly. It's just beyond arrogance. It's beyond narcissism. Like, you all of a sudden are the best thing ever. I am Jesus Christ incarnate. That's that.
That just reminds me of Family Guy. You ever seen that episode where Peter gets like his static electricity? He goes, "Guys, don't be alarmed, but I think I might be Jesus."
No.
Yeah.
But that's a perfect example of that. There was too much activity in his brain. He's like, I'm Jesus.
Yeah.
When people are manic, because, okay, what's happening when you're manic is there's way too much activity in your brain. Too much is happening. Depression, not enough is happening. Manic, way too much is happening. You don't need to sleep. Yeah. I have had, I had a friend who, he was in a manic episode, he didn't sleep for 5 days. They're more talkative than usual. And again, you have to consider where their baseline is. If this is a normally talkative individual, they have to be super talkative. If this is somebody who never talks, they have to be talking. Again, they're just chirp, 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 chirp. Not only that, they're not only more talkative than usual, but they can't stay on topic. So they're over here, and then there's a squirrel, and then there's a bright light, and then there's a shiny object, and it's really hard to follow them in their conversation. They're easily distracted. And so literally they can be talking to you, or doing one thing. Okay, squirrel over here. Squirrel over there. They don't focus very well. Increasing goal-directed activity. Yes. But again, this is commonly why people are like, yes, I need to be manic for a while. I'll get so much done. Not necessarily. Some people that I know that have experienced manic episodes, yeah, they'll clean their house with a toothbrush and it'll be like shiny.
What?
Yeah. Some people will write a book. Other people, on the other hand, they will buy 100 VCRs, take them all apart and try to put them back together because they're going to resell them. So their house is just like full of VCRs. So there's some sort of goal in mind that they're going to try to get to. They're going to try to start a business during this manic episode, and it's just a hot mess.
That's what I think about the dude when I drive to work. I don't know if you've ever, I don't think, maybe you have, but there's this house, and this dude's front yard is full of lawnmowers.
Where is that?
I don't even know the street name. I drive by it every day going to work, and his front driveway is just lawnmowers.
That is a very high level of goal-directed activity, unless he's collecting lawnmowers.
Yeah, unless he's, I don't know. I was like, dude, how many lawnmowers?
Maybe he's, but it doesn't, oh god, yeah. Yeah. And then possibly, and this is what usually gets people's attention as well, there's an excessive involvement in activities that have a high potential for negative consequences. So some individuals will, they will spend excessively, so they'll max out credit cards. Other individuals, they might have risky sexual encounters. They might use drugs that they've never used. Maybe they'll hop on a plane, fly to Fort Lauderdale, and make it rain in a strip club. Again, just absolutely impulsive, not thinking anything through, and of course they go toward the risky behaviors. Drive at faster speeds, ramp their car, you name it. That's usually what gets some people's attention. So again, you need, all you need are 3 of those. 3 of them. For 1 week. Okay, then, for the last part of the manic episode, and then we'll end this, there's an impairment in social or occupational functioning or to necessitate hospitalization. Yes, some people's manic episodes, and I'll talk more about this on Thursday, do necessitate hospitalization because it's so bad. Sometimes it gets into the point of psychosis. But yeah, if I am boarding a plane to Fort Lauderdale to make it rain, I'm not going to work. Maybe I haven't been home in a week, and so I'm going to get broken up with. My children forgot who I was. The episode is not attributable to the effects of substance abuse or other medical condition. Yes, this is one thing that I kind of had to deal with when I was working at Region 2, in that it was sometimes hard to determine, like, okay, is somebody high on meth or are they manic? Because honestly, the symptomatology is very similar. When people are manic, or when people are high on meth or they're tweaking, those symptoms that we just talked about are very common. And so it was tough sometimes to determine, like, especially with somebody who is a meth user that is bipolar, to determine, like, are you in a manic episode or did you use last night? We kind of had to sort that out a little bit. Okay, so that's where we're going to stop for today. I hope everybody has an